Namaste, Namaskar, and Vanakkam to all of you. We are in Chennai, that's why Vanakkam I said. In fact, today, in the time of social distancing, when people are saying not to do the handshake, I think Namaste is the best way. I welcome our viewers to this particular session of the Web Talk. Now, in this lockdown phase, when most of us we were at home, and those who have kids in their house, these pictures are quite familiar to each one of them. A superhero is having the supernatural power, who is dedicated to fight the evil of the universe, protect the public, and battle the supervillains. This is all these pictures are quite familiar to us. Now, in the these are the superheroes, but in the fight against COVID-19, you are the real superhero. And so a big thank you to all the doctors, to all the viewers of the evening. A big thank you to each one of you. Now, I take this opportunity to share with you that when you were all fighting COVID and fighting at the leading from the front, now we at Chennai, at Tablets India, we were also involved in some special activity. Tablets India actually have been distributing 1100 freshly cooked food packets every day to the people who are under the below poverty line and who lost their daily wages since the first lockdown period. And this is in collaboration with our Annadanam Center, which is located at Tondiarpet, Chennai. In fact, you can see some of the pictures, and you also can see some of the paper cuttings which were published in the local daily. So this is our corporate social responsibility. As a part of that, we have been doing this, and it will continue till the time this lockdown continues, and we propose to do it in the days to come also.
There must be some reason there that's we getting our NICUs are getting more. And in the same breath, can you just also highlight what is the incidence across when we have the NNPD data and we also have certain fresh data available to us? Can you just elaborate a little bit on that, please?
Yeah. Hello, everyone. Good evening. If we look at the incidence of neonatal sepsis in Western countries and India, it is contrastingly different. If we look at the data in the US, then the incidence of sepsis will be something around 1 per 1,000 live births. It is live births, not the NICU babies. But if you compare it with the Indian situation, though we have very less data available, like we already said, NNPD 2003 data is there, in which the sepsis in neonate has been found to be something around 38 per 1,000 live births, and that is only in the babies who have been delivered in the tertiary care institutions. So if we compare these two data, where in the USA you have most of the delivery happening in the institutions only, and the sepsis incidence is much higher in the Indian situations. That is quite a old data. If you look at the recent data in the Danish study, in that also the sepsis incidence is around 20% of, not percent, 20 per 1,000 live births. So even the recent study has found that the incidence per live births, per 1,000 live births is much higher than the incidence.
Anyway, Naveen, you can carry on in the meantime.
Yeah, so our incidence in our Indian situation, whatever studies we have is much higher than what the incidence of sepsis is there in the US. So that is in across the per 1,000 live births. If we look at the incidence of neonatal sepsis in NICU baby, the recent Danish study has found that the incidence is something around 15 to 20% of NICU babies. That includes culture negative sepsis also. So this incidence is also relatively much higher than the the incidence of sepsis which is there in the Western countries. Now, the reason, probable reason could be that one of the most important reasons could be the antenatal care. So, antenatal care in India, there are many pregnant mothers who don't get a good antenatal care, or they are getting in a peripheral center. That is one of the. And if you look at the organisms are also quite different in babies who are born in the Western countries versus the babies who are born in our situations. In Western countries, uh, the organisms group B step is much commoner. In NICU infected babies, the cons is much commoner. While in India, in fact, the recent study has also found it is the predominantly gram-negative organism, even if we talk about early onset sepsis also. So I think we are going to talk about that, what is early onset sepsis and the late onset.
I think, so maybe, someone can take up like what is the terminology and why do we actually need to differentiate between an early onset sepsis, a late onset sepsis,
Okay.
and why would it make such a, always talk in these terminologies in NICUs, but what is the relevance?
When we say early versus late onset sepsis, it's the onset of sepsis from the time of birth. Usually it's taken up to 72 hours of age as early onset sepsis, and after that as late onset sepsis. The reason why we take this differentiation is the origin or the source of sepsis in early onset cases is usually the maternal flora, whereas in the late onset sepsis, it's mostly from the hospital or the postnatal environment. So the bacteria may be different, the mortality may be different, and also the incidence of meningitis will be different in early versus late onset sepsis.
Why, Pradeep, you think early and late in Indian scenarios, we have the same organism, in Western scenarios, they have different organisms?
Yes, the studies have shown that in India, whether we are seeing the late onset or early onset sepsis, the organisms are mostly the gram-negative bacteria, unlike the West where they have more of GBS, which is very, very uncommon in India. So the reason maybe one is the hygiene, of course, now that is also improving with time. So with time, we may see the change in flora. Secondly, these mothers may be coming from hospital settings also. So even in early onset sepsis, you will see mostly gram-negative bacteria, and even the drug resistance is very high in these bacteria. We'll discuss the study later on.
Okay. So another thing which we are always talking about, whether it's a Danish study or whether we're talking about the data from the NNPD, Haripas, what do we have from the community? Because maybe the community data is completely different than what we are actually, and we as private practitioners are working in community, getting a lot of data from the community, not from these tertiary level. Dennis is AIMS and Safdarjung, and which are heavy load systems.
Yes, you're truly saying they are from 3 tertiary centers, MAMC, AIMS, and Safdarjung. So that data we cannot extrapolate to the community. But actually, frankly speaking, the recent data, even from the community, is showing that the level of drug resistance is very high, even in the community.
Okay. So that's so we talked about the community. Now, so Gopal, we just wanted to talk about what is this risk-based approach to finding out early onset sepsis, and there are so many calculators available in the market on the web these days. So maybe you can put a little light on, should we use these calculators for management?
For this, there are most of the early onset sepsis, usually it's attributed to maternal risk factors. If I name few of them, it would be foul-smelling liquor, preterm premature rupture of membrane, prolonged labor, and features of chorionitis. There are multiple factors. There are various studies on that which define certain risk factors which are at high risk and certain risk factors are at low risk. If you take into consideration local factors, suppose you take up studies from AIMS, PGI, and you try to look at the risk factors, this will be more relevant to our own scenarios. So there are various risk factors. AIMS like they use 7 risk factors. Out of that, if there are 3 are present.
Dr. Gopal, sorry to interrupt you. Voice is not very clear. So can you just please put the mic near to you? Yes,
Yeah.
sorry.
So like in AIMS, we use 7 risk factors, and out of them, if 3 are positive or mother has false smelling liquor, definitely we need to start antibiotics. So risk-based approach is you take into consideration various risk factors and you decide whether to start antibiotic or just observe the kid. Suppose this applies only to babies who are asymptomatic. You cannot apply a baby, suppose mother has leaking for 12 hours and baby is symptomatic, you need to start antibiotic. Risk factor scoring approach will only be to limit babies who don't have symptoms, and you need to just observe whether they're at risk and avoid giving antibiotics. Actually, we don't need it. If you look at Western data, they have come to a predictive model where they use online newborn SIPS calculators, there are various calculators. And depending on the risk calculated, suppose it's more than 1, you need to take a blood culture and just observe. If the risk is more than 3, you need just to start antibiotic immediately. So depending on that, such risk factors, yes, we have seen here. The screen shows that there are 3 calculations. If the baby is well and risk is almost 7.7, you need to start antibiotic. Any risk more than equals to 3, you need to start antibiotics. More than equals to 1 to 3, you need to do a blood culture and observe. That's what Western people follow. What in PGI we followed was a perinatal risk scoring, which was which used a multivariate predictive model done in a thesis. And we came out with multiple scoring. We assigned values to each of the scores. And if the score was 0 to 6, we just observed the kid. If it was more than equals to 7, we started antibiotics. And later on, we decided when to stop. If mother has clinical chorioamnitis, frank chorioamnitis, or there are severe risk factors such as leaking is more than 72 hours, we usually started antibiotics. So crux would be like, don't take Western data and use it in your own setup. Use your own local data, and objective is to avoid giving antibiotics for kids who don't need them. So we don't overtake.
So the takeaways from your discussion is that for symptomatic babies, there's no discussion.
Risk factor based scoring is not for symptomatic baby. This is for asymptomatic baby. Even if in asymptomatic, we are able to avoid giving antibiotics to 50% of the kids by doing a risk scoring based approach, I think we have done our job.
Yeah. So all babies, just because they are premature, do not need to be given an antibiotic.
Definitely.
This scoring would probably help everyone to decide whether to start or not the antibiotics.
So using this score, usually we don't miss on babies who are at risk. The score will definitely be high. So low score, just avoid antibiotics. That's what it says.
And the second point, you've already said that, the web-based calculators are not validated in Indian scenarios, so we probably should not use them.
Yes,
unless
we can do our own calculator. So,
sorry?
We can do our own calculator soon then.
Right, sooner or later. Now, other than that, we say, Naveen, probably you can take it up. The sepsis is a diagnosis. In any exam you go, any trial you go, you ask anyone, what is the diagnosis? They'll say neonatal sepsis. I'm sure there must be other diagnoses which are also present in newborn. So one, which are the common mimics, and how do you clinical clues for parents to the doctors to take and say, okay, this may be not sepsis.
Yeah, you have rightly said that any baby who comes to NICU, there is always a differential diagnosis that the sepsis could be there. So now because the sepsis has very high mortality as well as morbidity, and we don't want to waste our time. So the Gopal has already illustrated the risk factor based approach in asymptomatic babies, while the symptomatic babies who comes to NICU with some symptoms with symptoms, and we have to remember that the symptoms of sepsis, they are non-specific. They are not specific to sepsis as such only. So those symptoms can be mimicked by any other diseases also. So commonly, like, we have to take what are the basic history, the risk factors are there or not there. So if you have a risk factor, then the sepsis goes higher on the list. If you don't have the risk factor, then the sepsis will come down on the list. The second is what are the clinical examination which can give us some clues. Like you can say the hypothermia, simple hypothermia in a small baby who is lying with the mother, especially in the winter season in our northern India, a simple hypothermia can make the baby worse, and those babies who are LBW babies, especially less than 2 kg, they may need admission to the nursery or NICU just because of simple plain hypothermia. The second could be hypoglycemia. A similar situation of IUGR babies where you have the feeding issues, not feeding well initially, and then they land up in a hypoglycemia. So hypothermia, hypoglycemia, though they are the signs of sepsis also, but in a small babies, then you have only these isolated problem. You may not have sepsis along with this. Now the problem is that the babies who land up very sick, suddenly crashed baby who come to NICU with severe sickness. Now those babies we need to differentiate that whether is important to differentiate whether they have sepsis so that we can treat it on those lines, or they have something else where the treatment could be entirely different from the sepsis. Like a term baby who's born was absolutely fine lying with the mother, comes on day 2, day 3 of life with convulsions and crashing and a pallor. The subrecurrent hemorrhage is one of the possibilities that this baby could be having. The other common mimics where the severe sickness these babies can land up is the congenital heart disease, which usually presents on day after 48 to 72 hours when the ductus starts closing. So all those duct-dependent lesions, those babies, they come to NICU either with the cyanosis, gasping, respiratory distress, or lethargy, not feeding well. On the other hand, the acyanotic heart disease can also come to NICU crashing baby like aortic arch hypoplasia or severe coarctation of aorta, where you have a baby who was well, but by the end of first week of life, they come with shock, severe shock, metabolic acidosis, respiratory distress, poor pulses, especially the femoral and the lower one.
So the pointer you are trying to make is that we should always keep other diagnoses. The child presenting at any point of time, we should keep other diagnoses in mind for sure. Keep those up top of the list, exclude them, and then reach the sepsis. Because sepsis, there would always be there. You will always end up starting an antibiotic, but always look for other things. And especially if you have, for example, an encephalopathy, which is out of proportion to the normal, like it could be inborn as a metabolism.
Yes, sudden crashing baby is probably one of the clues where the sepsis will be on a low down on the list rather than higher down on the list.
Right.
And IM, as you rightly said, by end of the first week of life, a good weight term baby deteriorating suddenly can be IM, and the other is congenital adrenal hyperplasia, where we are not doing when the baby is not getting screened initially in the first week, then you have a second, third week babies who comes with severe shock, hypotension, dehydration. These are the common life-threatening illness where if you treat it in time has a entirely different story about that.
One, obviously, so which you have already enumerated, an acidosis which is disproportionate to the level of sickness would also point towards an illness which is out of proportion. A shock which appears on second or third day, you said duct-dependent lesions. That's one particular thing. You have any dysmorphism anywhere in the body, that will obviously be something that is clinical examination. So it's overall, the point that we are trying to make here is that, any child who presents to NICU, all of them do not have sepsis. They may acquire sepsis later on, but most of them, 30 to 40%, would actually be admitting for other diagnosis, which often gets labeled as sepsis, and the child died of sepsis, but the child would have died in absence of a right diagnosis. Okay, so now, this is something which is interesting because most of the, discussions are about taking the help of lab in doing the diagnosis. So again, the point we are trying to make, if the child is symptomatic, you would have made a mind already that this is a child who is sepsis and I need to start antibiotics. So we need lab not to make a diagnosis, but to confirm the diagnosis and to identify. So I'll come first to the commonly held, discussion about what is a septic screen, and maybe also talk about a little bit about when it is required and when it should not be done. And before this, because I know during the course of discussion there will be multiple times that we'll be talking about sensitivity, specificity. So maybe Sunil, can you just briefly, for the benefit of audience, can explain what exactly these terms mean and how do we relate when it comes to sepsis screening infection?
So, as rightly said, most of the time we do not have a confirmatory diagnosis, whether whether the baby has a disease or not, whether he has sepsis or not in this scenario. So we are doing some certain tests, and each test has certain characteristics. Some tests are more sensitive, some tests are more specific. So we often come across these things. Well, clinically, in a bedside scenario where we are doing a test to identify a baby, whether this baby has sepsis or no sepsis, and by doing a test, we are trying to whether the child is sepsis or not. So in this type of scenario, positive predictive value or negative predictive value are they give us more confidence at the bedside. So let's say if the child test is positive, then what is the chance of having this disease? So the positive predictive value. And similarly, many tests they have good negative predictive value. So let's say a test is negative, then we are very sure that sepsis is not the diagnosis. So sometimes not one test, serial test might help, and many tests have good negative predictive value. So this negative predictive value, positive predictive value, we have to also understand that this will change with the prevalence. If the incidence is high or low, and then if there are different settings, then PPV and NPV will change. But this sensitivity and specificity normally they do not change with prevalence.
Okay, so as you said, like the most common test that we come across is the complete blood count, and this is so. Maybe can someone explain why, when should we doing it? What is the reliance we should put on in diagnosis? Because many times we say, oh, iska count zyada tha, so that's why he has an infection, and that's the most common discussion I hear whenever it comes to
One thing for newborns, we must be sure that it's not a single value that is important. The serial values are important, number one. Number two, suppose the baby is just 8 hours of age and you get a TLC of 25,000 or even 30,000, one gets worried. It's not so. So we should look at these charts. For a term baby, we use Monroe's charts. For preterms, we use Mozzino charts. And you are seeing it's just a neutrophil count. This is not the total leukocyte count. And the neutrophil count goes close to 30,000 in term babies and as much as 25,000 in preterm babies. Whereas the total leukocyte count can be very high. One reason for that is initially after birth, due to stress, there may be a high count of nucleated RBCs, which may be counted as lymphocytes by the Coulter. So you get a high TLC. So one should request the lab to give the corrected TLC. Number two, just a high value of TLC usually is not worrisome, but a low value, especially if the TLC is below 5,000 and the absolute neutrophil count is below 1,000, they are stronger indicators that the baby is septic. Serial values are more important than single values. Suppose you have repeatedly done CBC and the counts are coming as normal, that gives more of a reassurance that the baby is not septic. But a single high TLC value does not correlate with sepsis.
So the point which Pradeep is trying to make across is that, just looking at a TLC value in the lab report, because the lab would always put it as bold because it is out of range of 4 to 11,000, does not mean that the child has sepsis. We need to look at the chart, compare the value, and if it falls less than within the range, maybe not. Now, the other point you are already made that low TLC is much more specific. This thing. When should you do it? Like, say, for example, if the child you decided to start with antibiotics, should I be doing it? Yes or no?
See, just after birth, there is no point immediately doing the counts. But Suppose I have to start antibiotics. My antibiotic decision immediately may not be decided by the TLC count. It will be decided by other clinical features also. But a low TLC, in addition to the clinical features, will add on to the value of diagnosis for sepsis. A high TLC usually does not. If repeatedly the TLC is coming normal, then it's usually unlikely to be sepsis, provided other things are normal. And number two, if we have done TLC once, we should repeat after 12 hours, because at least two CBC counts have more of a negative predictive value than a single one.
So what you're trying to put across is that, like, a child, well, early onset sepsis, any child who's symptomatic where you decided to start antibiotics, we do a CBC at that point of time, may or may not, but if you do, just look at a repeat value.
Yes.
Correct. So as he's already pointed out, WBC and ANC are the more predictive, and that we'll look at. The second point I would want to, someone to elaborate, maybe, Gopal, you could discuss the value of CRP. It is again the most commonest test, on the panel of all NICUs. And what is its value? When do you use it? Should we even be using it? Because some people do not like CRP at all now.
We'll take each question one by one. First of all, the crux is what you have said is to rule. Always think of sepsis, but always think of sepsis mimics also. Don't always think of sepsis. And the crux of neonatal sepsis is you need to rule it out rather than wait and watch for the lab reports to come positive. Suppose I'll talk of two scenarios here. If a baby is asymptomatic, just with risk factor, suppose he has perinatal risk factor, which we already discussed, and who is at low probability of sepsis in after 72 hours. Suppose he has just an episode of vomiting, one episode of apnea, where you have time to wait for it. Maybe will give you time. Where you think sepsis could be a possibility, but you need to rule it out. There, the role of sepsis screen or predominantly CRP comes in. You always think that CRP is an inflammatory marker, not an infectious marker. Wherever there is inflammation, such as I would say meconium aspiration, delayed transition, any hemolysis, any small cut in the body will trigger the CRP. And second thing is CRP starts rising in 6 to 12 hours and peaks at around 24 to 40 hours. So suppose baby has symptoms or a baby is asymptomatic, you do a CRP after 12 hours, very likely you will get a negative value of that CRP. So you're not very sure whether you've ruled it out or not. So what people have done, they've followed up serially to see where the peak is. And they found that around 24 to 48 hours is the right time to do CRP. If you get serial values of 2 CRP, which is negative, that definitely rules out CRP rather than acting on single CRP. On the contrary, if your baby is symptomatic, CRP would not help, because suppose there was a clinical coronitis, baby is symptomatic, negative CRP would not help you in stopping antibiotics or withholding antibiotics, I would say. So even if CRP is negative, you anyway start antibiotic because baby is at risk factor and is symptomatic. So rather not do CRP, wait for culture and look how the baby is behaving. Look clinically and look at culture. CRP has a value only to rule out. So it is a good negative predictive value, particularly in early onset sepsis where maternal risk factors also come into play.
So in short, what Gopal is saying, do not do an CRP in early onset sepsis when you're deciding to start antibiotics, because it's useless. Don't waste your money. Use that money for blood culture.
And single cutoff of 10, like whatever we to take it as a rule of thumb, like 10 milligram per liter is the standard cutoff. But that again, the standard cutoff is not applicable in first 48 hours because the values actually rise after birth. So that value can be.
It should not be done. Maybe, if you're planning, if you are in confusion, you want to stop antibiotics, doing 2 CRPs may help you in deciding to stop antibiotics. Like some people use it for monitoring the severity of illness. Like, and they pehle to CRP kal 100 tha, aaj 150 ho gaya. Does it really make sense?
I would say go with culture report and say clinically. If you feel baby is improving clinically, there is no bleed, baby is like oxygen requirement has come down, shock is improving. Even if CRP is worsening, I would not hike antibiotics. I know baby is clinically improving. So that is a clinical decision. That is, rather than chasing labs, I would say look at the baby and decide. So once baby is positive CRP, you start antibiotics and then decide clinically when to stop.
The message from the expert is that do not look at a value, but like you may just have to look at if it's persistently present positive after so many days, you may think whether you have a complication present or not.
Yeah.
But do not make your decision change because people keep changing the antibiotics based on that. Now, this is the most interesting one. Blood culture, and often there is now the culture of taking blood cultures is increasing. So, across. So, I mean, the people still have doubts about, what is the best way to take the culture, how many bottles, what site. Can briefly one-liners on, someone can take it up, like maybe Sunil, you can take it up. What should be done? How many bottles? Yes, 1, 2.
So as you rightly said, there is a culture of not taking blood culture in our NICUs. We have to understand the reason actually why, because many times the doctors, they think the blood culture will come negative. So why to send? So most of the time the reason is because we are not taking adequate amount of blood. We are not taking adequate amount of blood. So most of the time doctor will add 0.2, 0.5 ml. So normally it's said that at least 1 ml of blood should be added to the bactec bottle. So as far as number of bottle is concerned, it should be 2, and from 2 different sites, not from the same site, 2 different sites, 2 bottles. If you are sending 2 bottles, one should be aerobic and one should be anaerobic, preferably. So that should be the thing I want to say basically. About the sampling site, yes, if you're putting a peripheral cannula, then we can take at the time, but we cannot take from a cannula which is already been put. So it should be a fresh venipuncture or with the fresh cannulation, like umbilical vein and umbilical artery catheter. Yes, umbilical venous blood are likely to be contaminated. So from UVC we should not take. And for umbilical artery catheter, we can take if we have put recently. So peripheral cannula, peripheral prick and cannula, those are the good standards.
The point. So any fresh cannulation, take it. If it is old, do not take it. Now there are different methods. Like one is the conventional blood broth, the bile broth method. Another is back alert. So what is the difference in brief? And which one should you recommend? One, if you have to forget about the difference, you just tell which one should use.
Definitely, this bactec are good actually, and these are back alert, just you are saying. So many labs, they can detect the growth early, and once the growth is there, then it will give a signal. And it is said in gram-negative or if the gram-negative organism is growing, then normally by 16, 18 hours, it will be positive. And normally we say till 48 hours to 72 hours. If by 72 hours, if something is growing, then the chances is that it is the causative bacteria. If something is growing after 72 hours, then the chances of contamination again rises.
So how do you differentiate between true infection and contamination?
So one is the time to positivity, anything growing after 72 hours. Second, if you are sending 2 cultures and if the organism is growing in only one, then again the chances of contamination is high, is likely. And third, maybe if you're growing in one bottle is growing, one bottle is not growing, then I will say it might be contamination. Finally, we have to see the baby also. If the child is not it's not fitting. The child is well, and if one bottle is growing and the other bottle is not growing, then definitely we should think it is a contaminant.
Well, what you said, it was right that we should take, ideally it's written books that you should take 2 samples. But given a small baby and given the cost involved, I mean, I would ask the rest of the panelists, how many would go for 1 and how many would go for 2 blood cultures in, say, 500 grams baby?
Yeah, at one point of time, I'll take only 1 culture, and maybe if the baby is not improving after 48 to 72 hours of changing antibiotic, then you can think of taking second. But taking one culture at one point of time is good enough, should be good enough. I don't know what others are practicing.
Bactec culture is actually quite sensitive. So I think taking bactec culture, if you're doing a bactec culture, no point in doing 2.
I think if you're sending 1, then at least give 1 ml. Most of the time, you have to take at least 1 ml of the blood in the bactec. the benefit of sending 2 cultures, it will increase your yield by 20 to 30%.
No, that is understandable. That's for sure. That's the truth, and that is science. But when we say practical, when we're talking about practical, the cost becomes like so one culture costs around 30.
If you do a cost-effective analysis, the cost of giving unnecessary antibiotics will be much more than having a culture which is 1,000-1,500 rupees. It is equal to 1 day of antibiotic therapy, I will say.
So the point which the experts are saying, which to conclude, it is good to take 2. I mean, it's okay to do with 1, but it is good to take 2. And if your culture becomes positive very early, then it is probably true infection. If it gets positive late, it's probably a contaminant, and you may just, especially if the child is not symptomatic. And in the same breath, they're saying is that you need to take at least 1 ml of blood. And if you have to conserve blood, do not waste it on CRP. Just do the blood culture. It will give you much more information. Using backtech methods are much more reliable, and the yield is almost 90% with 80 to 90%. The back alert probably has a minor benefit over backtech in terms of detecting better fungal infections. But if you do not deal with the fungal infection too much, anyone is good enough. But if you don't have any, you can still use the bile broth, because that still picks up around 40 to 50% of blood culture positivity.
Just to add one more thing, if you have taken the culture from a central line and the line has been there for some time and it's showing a positive culture at least repeatedly, then it's better to take the culture from some other place or from a peripheral vein just to confirm it's not only colonization.
And plus remove that line. Okay, so now this is another interesting question, because everybody talks, they do not want to do lumbar puncture on one or the other pretext. The baby was not hemodynamically stable, was on a ventilator. When should we do it, and when certainly we should not be doing it, and when not like something which and the questions which are clear: when should you do a repeat LP, if at all you suggest, and how do you interpret the values in term and preterm, and how do you interpret the traumatic LP? Should we actually be even talking, trying to interpret traumatic LP is the question. Gopal, maybe you can take that up. Sorry.
Indications, if I keep it simple, it's any baby who is symptomatic and who is on antibiotic. If there is suspected sepsis and baby symptomatic, definitely you need to do an LP. Asymptomatic with positive labs, definitely yes. Asymptomatic with culture positive, yes. A baby who is started on antibiotics just because of perinatal risk factor, but is asymptomatic, I would withhold doing an LP. That's the only indication of not doing an LP. Rest all babies, you need to do LP, because not doing an LP, you might miss out on meningitis. We need to rule out meningitis. That's the crux. So suppose you don't do an LP in early onset sepsis, even if baby is symptomatic, you might miss on 5% of meningitis. In late onset sepsis, meningitis rate is very high, 25%. 1/4 would have meningitis. So we need to rule it out. We need to do all LPs in all symptomatic babies. Repeat LP, I would say there are very few indications for repeat LP. Suppose we get a CSF culture positivity.
Sorry, I would request Dr. Gopal, you can take your mic a little closer.
I'm doing it.
Thank you.
So repeat LP, there are very few indications. So you suppose there is no clinical, suppose you diagnose meningitis with biochemical or any other evidence, and you see that baby is not clinically improving in 40 to 72 hours, you can do a repeat LP. If the CSF culture is positive, and particularly in gram negative, you should do an LP after almost 72 hours, because that's the usual median time when CSF actually becomes sterile. If I would say atypical organism, suppose you get organism which is not common in an ICU, which has tendency to involve the brain, I would give an example of Acinetobacter. I would repeat an LP. That's the 3 indications for
the fungal as well.
Fungal, yes, definitely. Fungal, usually it's told like you need to repeat by 5 to 7 days, because fungal clearance takes some time. So by 5th day, you can do a repeat CSF and definitely send a CSF culture. If you talk of interpretation of values in preterm and term, again, the data is quite like, you open up every book, every journal, you would find different values. So standard cutoff is like low sugar of almost less than 35. protein of more than 170 and cell count of more than 30. This is what is a single value parameter, I would say, but that is not good enough to do it. So there are various, like even there is difference in preterm and terms. Preterms have more WBCs, more protein, and sugar are slightly less compared to a term babies. So there are different cutoffs. In PGI, we used to, the slide which has been projected is from PGI. So this was a standard which we used from, this was from a published article. So we used this cutoff from a suspected and proven different parameters of WBC and sugar and protein. So always remember, look at the table and do a per day, like if you open up Nelson, you will find 0 to 7 days, 8 to 30 days. There are different parameters of protein and sugar because the values actually change as per days, even in term and preterm. So we need to know what value you need to use. If for a single value, you can use any standard values which are there in books. Traumatic LP doing, I would say, better avoid sending biochemical parameters and cell count in traumatic LP. It's frank traumatic, definitely don't send it. Rather send a gram stain and culture. That will help you identifying infection organism. If you suppose there is, it's not visually traumatic LP, but you get RBC count in the CSF parameter. If the count is more than 500, you would label it as traumatic and avoid correcting factors. There are various factors which you use in pediatric, like bigger babies, like 500 WBC, RBC, you take 1 WBC. But using that factors in newborns actually doesn't work. It reduces sensitivity. We might miss out on meningitis. So rather avoid.
So you recommend doing it after 24 hours again?
I would say at least 48 hours because some amount of blood might have leaked into the CSF. So clearance will take some time. Better wait for 48 hours. Usually biochemical parameters doesn't change faster. So 48 hours later on, you might get some high protein and WBC compounds.
Thank you. So what the expert is saying, that any child who is on more than 48 hours of antibiotics, then you must in your NICU do an LP to rule out whether there is a coexistence, because you're treating him for presumed infection, then you must do an LP for sure. Now, I would want someone to take this up because this is something which is, nowadays very commonly used. One is a procalcitonin and other is a biofire, and biofire panels are, rapidly expanding. So can someone take this up, please?
Yes, this is the multiplex PCR because blood culture takes time to come and the baby is sick, so we can't wait. So time is important at this time. So when we use multiplex PCR, it is actually to amplify several different DNA sequences simultaneously, as if you are performing separate PCR reactions all together in one reaction. So it contains both gram-negative bacteria, gram-positive bacteria, fungi, as well as it also gives you antibiotic resistance genes. The runtime is just 1 hour, and within a couple of hours, you will get that the blood culture is positive for some bacteria. The difference from blood culture is here you will get the result positive only among these specified bacteria, like it is pre-decided that these bacteria will be amplified, like Klebsiella, E. coli, etc. What has been decided. So usually the most common pathogens are kept in this. But still you will have to do the blood culture. The advantage is you will know earlier that the culture is positive or negative with the biofire. So if it's negative, you may stop antibiotics earlier. You may de-escalate antibiotics earlier, and it will lead to antibiotic stewardship. Suppose it is showing that it's not a resistant gene, so you can come down to lower grade of antibiotics. But if it's showing a multi-drug resistant gene, you may need to escalate earlier. This may also improve the outcomes. What ultimately happens is, although this test is costlier, but in the long run, it may save more lives, and also it may save the antibiotics, especially those antibiotics which are reserved category. But still, to date, we should do blood culture along with these tests.
And then this panel is also available for meningitis and encephalitis also.
Yes, for CSF also it's available.
One thing, Dr. Sanjay, when blood culture is positive, then only we can do blood, this biofire in blood. So if the blood culture is not growing any organism, we cannot do. It is not done basically.
No, it will show only if there are, the blood contains bacteria,
Yeah.
but the advantage is you will get to know earlier than the blood culture that some growth is there.
So
Correct.
if there is some growth,
Yes.
it will take some more time to identify the exact organism. But with this biofire, within 1 or 2 hours, we will be able to
Yes.
know the organism. But there has to be some growth.
Yes, the growth has to be there, only then it will show, and the sensitivity will be better than the culture actually.
Yes, the sensitivity of this is almost 98%.
Yes.
If the bacteria are present, and the new panel they are developing is almost going to contain 43 bacteria and viruses and maybe fungi, I guess. So procalcitonin, this is something which is now gradually creeping into the NICUs these days. So anyone to take this up, please, because it is a costly test.
Procalcitonin is another inflammatory marker like CRP. So the value is nearly same. The only difference between CRP and procalcitonin is that it rises relatively earlier than CRP, and the negative predictive value is slightly higher than the CRP. It means that if you have a procalcitonin which is negative, then the chances that infection is not there is much better, something around 80 to 90%. But as a alone single marker for infection, the procalcitonin has the nearly same importance at that of CRP, and the cost is almost 5 to 6 times higher than the cost of the CRP.
So one line question: would you recommend doing this in the current scenario? Yes or no?
No, I won't recommend it to do it. I will recommend to do only when you want to just rule out sepsis, then you can do it. Otherwise, routinely it is not to be done, and I am not doing it at all.
I would
it is
like
better
to
to do blood culture, one more blood culture, rather than going for the procalcitonin.
Gopal,
I'd just like to add one point. Actually, I think it helps in differentiating viral from bacterial. So if a procal is positive, it very likely points to a bacterial sepsis. So that's, I think, a current scenario you might use procal more considering COVID.
Another thing I would like to add is, sorry, we are continuing.
Pradeep, go ahead, please.
Okay. Even a normal newborn mounts a very high procal response in the initial couple of hours. Suppose you do it at 24 hours, the procal will be very high. So the false positive rate will be very high for the initial 48 hours and should be avoided during this time. Otherwise, you will treat more babies than required.
Sure. Sunil, you wanted to say the last word on that?
So basically, it can be positive in viral also, and also in fungal. So it doesn't say only in bacterial infection. So again, it's a acute phase reactant, can be positive in viral, can be positive in fungal.
So
but less commonly in viral. Yes.
The message for the audience in simple term is, since the experts, they have not decided among themselves, so you can do away with procal. Is that right?
It is a moderate CRP.
No.
It will be a higher cost.
Yeah.
See,
so
procal is better than CRP in certain things. You will know it rises earlier than CRP, but the only thing is for early onset sepsis, you will get a very high false positive report. So it should be avoided during that time. But otherwise, it's better than CRP.
So late onset, yes. Early onset, maybe no.
Yes.
Correct. So we move on to the, this is supportive treatment. And here we, talk about the most common these days is the probiotics. Everybody wants to talk about that. Maybe Pradeep, you can elaborate on this.
Okay. Probiotics, they definitely decrease mortality in very low birth weight babies and NEC. The question regarding whether they decrease late onset sepsis, if you see this Cochrane meta-analysis, it does not show. But there have been meta-analysis done after this, which show that probiotics decrease late onset sepsis. Now, it has shown that the effect is more in human milk fed preterm babies. Number two, the combination of probiotics were more effective than single strains. And the reason may be because it's a variable duration of exclusive human milk feeding, and the mixture would provide a better ecological barrier and a more diverse immunological stimulation than a single strain. Problem is, if you do a subgroup analysis or a stratified analysis for extremely low birth weight babies, out of the 25 studies, only 2 showed this data, and it was not statistically significant. So the population at the maximum risk, that is the extremely low birth weight baby, did not show benefit of probiotics. Only a couple of small studies did show some trend.
Pradeep, can we just leave the studies aside?
Okay.
Just give a very clear guideline to the audience. Should they?
So the message is
Yeah.
probiotics decrease late onset sepsis in very low birth weight babies, but in extremely low birth weight babies, we need more data to prove that.
No, but at the current moment, should they be considering, because this is something which, like, some people in sepsis, we need to talk about what we need to do today. Should we be using probiotics? Yes or no?
Probiotics, the problem with probiotics is there should be some standardization, because most of these are not given as drugs, but as food additives. So the quality control should be ensured, which is a big problem. So which strain, for how long, and what dose, this question is still open to debate. But overall, they have shown that there is benefit of probiotics in late onset sepsis, as well as mortality and NEC. If your unit has a very high prevalence of any of these problems, then they should be used.
So the bottom line is that if you have a high incidence of sepsis and an NEC, you should consider using probiotics. The only caution which Pradeep is mentioning is that you should take it from a source which has been doing and working in neonatal and has been shown to work in some other neonatal population, rather than, and stability of the product is a bigger issue in Indian scenarios, because as you rightly said, some probiotics need different storage conditions. They may not be rightly stored in pharmacies or the roadside pharmacies as we normally are used to. So it's a good thing to do. But if your incidence of sepsis is low, maybe you could, think otherwise. But otherwise, it's not a bad thing. And some who are proponents like Dr. Saurabh says, we don't need any further evidence to prove the benefit of probiotics in sepsis. Immunoglobulin is something which most people are using these days, left, right, and center. So what is your take on that?
The INIS trial, which is a large trial, did not show any benefit of immunoglobulin. Even the trend was not there, and it was a huge trial. So in today's date, it's not evidence-based strategy to give immunoglobulin. Regarding pentaglobulin, which is IgM-enriched immunoglobulin, I think some data is there, but more evidence is required.
Correct. So we do not use the recommend.
I'll just want to comment on this. We have to take this INS study with pinch of salt. If you look at the organisms which they have encountered during this study, almost 80% of the organisms are the gram-positive organisms. So actually this study, they have given immunoglobulins for gram-positive, treating a sepsis of gram-positive. While in our situation, the sepsis or the causative organism is entirely different, and 60 to 70% or maybe more than that organism is gram-negative organism, which are very fulminant, very life-threatening, has case fatality ratio of nearly about 60 to 70%.
So Naveen, do you use it or not use it?
I personally use it in very severe case of sepsis, where I feel that even the antibiotic don't give us the time to save the baby for that only, in very few selected babies. And especially as Pradeep said, the IgM enriched, the data has been found to be slightly better than the the simple IgG immunoglobulins.
So the point is that
not routinely in all cases of sepsis. If you want to use it, only in very severe case gram-negative fulminant sepsis.
So the point which the experts are saying, in routine where you have enough time for antibiotics to act, do not use it. if you are using it in the fulminant case where the outcome is death, maybe plus minus, but we do not know as of now whether that's the right strategy. Is that right?
Yes.
Yeah, correctly said, Sanjay.
Right. So then, like GCSF is something which we often get neutropenia, and somebody was saying CBC low ANC is very predictive. Should you be using CSF? Maybe Sunil can answer. He's been quiet for a long time.
Basically, when there is neutropenia and the clinical sepsis, we have used it in babies, and after this, at least the ANC increases. So I have used it, and we are using it. If there is low ANC and the child is clinically septic, in an asymptomatic baby with low ANC, I don't think it is that much required.
So rest people also use severe sepsis with low ANC, ACS, GCSF.
We have not used till date.
Like severe sepsis, baby has scleroderma, severe shock, and you find ANC is 500. Yes, less than 1700 ANC, there is some data of mortality decreases. So we have used in few cases, but the moment ANC starts rising, we stop it. Although there is no strong evidence for it, but we have used in rare cases.
So when the outcome again, the bottom line, we are again trying to say if the outcome is death, and you're probably going to lose the baby in next 24 hours. Maybe everybody tries everything and that what you're doing is no different what then the experts are doing. They also try something to save. It may or may not be beneficial in the long run, but at least that's when the outcome is death, you would still want to use it. And exchange transfusion is something which Western people are not very fond of, but obviously there are many people in the country who are doing, at least for those sick gram-negative scleromatous babies. So maybe Sunil, you have done a lot of exchanges for this particular indication.
You're right. At one time we are doing it more frequently, but I will say where the sepsis, there are high incidence sepsis, and then it do help at least in decreasing the bacterial count. I will say the burden in the baby, but we are not sure it is associated complications also. It's not a safe procedure. There are associated. It is highly, I'll say, it is a very high risk procedure. There are chances of bradyarrhythmia and worsening of shock. So it can be, we can give a trial when there is severe sepsis and you are thinking nothing is working. So this is the last rate.
Again, the point, these adjuncts. So the whole idea that I was trying to put across, probiotics where you may consider if your incidence of infection is high in your unit and NEC is high. And if all these measures, rest of them, you should use in a dying baby or moribund baby. In routine babies, there is no role for these kind of activities, whether it's IVIG, whether it is like So there is a question about lactoferrin. If someone wants to answer that, I'll go to the other.
I'd like to add about exchange transfusion. Actually, I was the study which has been projected. I was there when the study was done. So we used only this study was only for more than 1 kilo baby. It's less than 1 kilo. If you do an exchange, there is high degree of chances of IVH. So more than 1 kilo, if there is scleroderma or there is severe shock, if you feel baby is not giving time, this doing an exchange actually buys you time, and usually shows that it decreases mortality. There is a trend toward decreased mortality. So definitely, I would go for exchange. We have saved number of babies after exchange.
Correct. So now the antibiotic stewardship is a term which is quite often being used. Can, in brief, explain what the whole concept is, not the points. What does it mean, and why do you want to do it?
The whole idea is to reduce the emergence of drug-resistant autism, to reduce the inappropriate misuse of antibiotic. Use antibiotic wherever it is required and use it aggressively for appropriate duration, whether it is a meningitis or it is only sepsis without meningitis or it is a septic arthritis. So appropriate use of antibiotic, aggressive use of antibiotic for proper duration. Antibiotic use only depend if you have a culture sensitivity, use only sensitive antibiotics, stop all other antibiotics, and use it And do not use antibiotics where there is no sepsis, where it is not required. Do not use prophylactic antibiotics. So this is the crunch of antibiotic stewardship, I can say in a short.
Gopal, maybe, there is a term which is called MIC, minimal inhibitory concentration. And this is present in the blood culture report. Maybe, for the ease of audience, they see it, but they often ignore it. So what do you interpret and how do you decide about the antibiotic in those cases?
Like suppose you have different MICs of antibiotic and all are sensitive. I would use an MIC which is like on the lowest MIC. Suppose it's like less than 1. Suppose you get an MIC of 1 and 8. I would use a lower value antibiotic rather than given high value MIC. That's the simple way of doing it. And I don't think we need to discuss anything else.
Yeah. So some people also get reports sensitive, intermediate sensitive, and resistant.
Yeah, so definitely if something is resistant and baby is not improving, that means that is not working. Suppose baby is improving clinically and the antibiogram is showing is resistant, maybe it's in vivo resistance.
Hello. Sanjay, बिल्कुल ठीक है.
Yeah. Definitely use a sensitive antibiotic with minimal MIC. If there's no sensitive antibiotic and you're using an intermediate sensitivity, better to use 2 antibiotics just to cover up. And if the baby is resistant, definitely you need to think of other causes and find it out. And do adjunctive therapy would help in this matter.
And Sunil, what do you use normally? I've just posted it for this thing, but can you explain the rationale behind meningitis 21 days, blood culture positive 14 days? This is what we've been following, but why should we be following this?
So basically, it's not. There is no evidence or there are no trials of lesser duration of therapy. I will say these are not evidence-based as of now. For meningitis, we normally give for 3 weeks. If there is no other complication, it's uncomplicated meningitis. So before stopping antibiotics, I think one should do an ultrasound head to look for any abscess or ventriculitis. And if there is no abscess or no ventriculitis, then after 3 weeks, we can stop. In blood culture positive and there is no meningitis, normally we give for 14 days. But there are certain certain bacteria, gram positive and cons. Like in cons, coagulase negative staphylococcus. If there is no meningitis, people have stopped after 10 days. So there we are trying to decrease the duration of antibiotics. And in cons bacteremia with no meningitis, we can stop it at around 10 days. And thirdly, like in culture negative sepsis, it's clinically probable sepsis and stream was positive for 5 to 7 days. But the last row, I will say in these things, many times we start antibiotics, and at the time you may not be in a position to withhold. So maybe you can start the antibiotics. There is no harm. But once the culture is negative, your reports are normal, the child is not looking like septic, then you should stop. My request is to stop at 36 to 48 hours, believe your lab, believe your culture, and by 48 hours the culture is sterile, the child is not behaving like sepsis. I will urge, do not continue antibiotics just for the sake the child is in NICU. So the last row, I think we should be focusing more on those babies where we have just started based on some risk factors, some symptoms. But at the end of 48 hours, we are wise enough.
Sure. So how do you decide? This is the question which often comes to our mind, and parents, the doctors we see whenever we interact, they say our first line is cefotaxime. Somebody says we start with ampigenta. How does one rationally and scientifically decide what he or she should start with, rather than, AIMS uses ampigenta, so we're using ampigenta, or PGI uses XY, so we use XY.
So basically, in the starting,
anyone can take up. I am just like
maybe Dr. Naveen, we can.
Yeah, the first line it is a dynamic process. It is not the fixed thing that the ampigenta used to work many decades back, and cefotaxime amikacin used to work a decade back, and now probably those are not working. So first line antibiotic, the one thing, it is a dynamic process. It is not a constant process of same antibiotics for many years. Number two, which type of baby you are treating? Are you treating a early onset sepsis are you treating a late onset sepsis? So first line antibiotic for early onset sepsis, the baby who's delivered in your hospital, and you probably know the antenatal risk factor, and then you start antibiotic. While on the other hand, the baby you receive, a outborn baby who already remained in some place in a hospital for a week or so, and then land up with you, and there your first line antibiotics will be probably different. But if you ask about just what blindly which antibiotic, you need to sort out the issue with in your unit itself. You take a last 6 months or 1 year's antibiogram, see the culture sensitivity report, that what sort of organism you are getting from the babies who are born, who are inborn, and what sort of organism you are getting from the babies who are outborn and referring and being referred from a specific unit. And sometimes you have a specific organism growing from a specific unit itself. So, and you know the sensitivity pattern, then you start the first line antibiotic accordingly, according to those babies who are referred from a particular unit. So there is, I won't able to answer as one liner that it is a cefotaxime amikacin, but probably amikacin remains a choice of as a first line antibiotic in most of the units, while the and plus the piperacillin tazobactam is usually the choice in most of the places, and right now also, except that if you have an outborn baby who are already infected, and then you have a very different sort of, maybe a colistin may be a choice in some of the baby right now, the sort of organism which we are getting as a drug resistance. So that is why we need to have a protocol fix for your unit itself, where you have a last year or so's antibiogram data available with you, and then accordingly you start an antibiotic. Be careful to start with a right dose and for appropriate duration. So you need to have a combination, that is for sure, that you cannot have a one antibiotic as a policy. You need to have a two antibiotics which cover most of the organisms which are mainly gram negative in our situations.
Correct. So the
probably
point,
piperacillin tazobactam plus amikacin is a decent choice right now if you don't have a dying moribund baby.
Yeah,
so the point which Dr. Naveen was trying to make was that we need to plot all the cultures which have grown positive in the last 1 year, plot and differentiate based on outborn and inborn babies, and then plot them and see how many were positive for a particular drug or a combination. And if your first line should be something like 70 to 80% of all organisms should be covered with that combination. For example, in this, where you see, I put a line at say 80, for example, 70. So 70, like this piptazamica is not a right choice as a first line therapy, the one which has been put in yellow. Whereas, say, for example, anything in green is, reaching our 70% mark. Although some people would say they would take 80% as their cutoff for them. But given the fact that in India, the incidence of drug resistance is high, you probably second line could be somewhere around 80 to 90%, and third line should be able to cover most of the organisms which are there. And Dr. Gopal, would you, based on the sickness, would you want to change, directly go to second line, or maybe a third line, which conditions which you will consider third line directly? And when do you switch from one first line to a second line?
So I would say, as rightly pointed out by both of you, the decision of antibiotic depends on the organism which we are dealing with. Suppose inborn we get what type of antibiotic, we should know that. And outborn, if you are referring to a particular unit, you should know that what type of organism actually has. And then you draw the antibiogram and decide first line, second line, third line. That can be variable as per inborn, outborn, as per unit referred. So if I feel I start antibiotic and I don't see clinical response in 40 to 72 hours, I would say clinically I judge no, baby is not improving, so I move to second line. But in case I find that baby is referred to me and baby is in severe shock, scleroderma, any signs of severe, like baby is in DIC, and baby might not give me time to escalate antibiotics, I might jump from directly to second line or third line, depending on severity of the illness.
So only in severe cases that you should jump. Otherwise, if the child is symptom-wise not very sick and you're just suspecting, you should probably stick on.
If time 40 does, then you change antibiotic.
Correct.
And do consider antifungal treatment, especially in a late onset sepsis where the baby remained in hospitalized.
And once the culture is positive, you then decide on the antibiogram and if required, step down on antibiotics.
So the point everybody is making, even if you have changed, do give 48 to, for 24 to 48 hours, at least 48 hours, not even 24, 48 to 72 hours for them to show a significant response to treatment. It's not going to happen in 12 hours as most people are, or the BP is still low, let's change the antibiotic to meropenem or just like, so it should be a rational decision rather than, more a kind of a reactionary decision. So with this, I thank you all the panelists, and I'm sure there are going to be a lot of questions which you would need to answer still. So I'll stop sharing my screen and take the questions now. And I think I've the question is, what is the decisional cutoff for NNF 2010 sepsis score? This is maybe Gopal, you can say.
That was predominantly the thesis was done on less than 35 weeks. That is only for preterms less than 35 weeks, and what sepsis risk score we get in Western countries that involves only more than 34 weeks. So there are two different group of
maybe, but 35 weeks is the answer.
Less than 35 weeks, yeah.
Yes, the answer. And Suja Mariam, hi Suja, she says, does fetal tachycardia alone become an indicator for starting antibiotic? Just because fetal tachycardia was there, and
yeah, I would like to answer this question.
Yes,
there
please.
was another question on triple I concept,
yes,
which is intrauterine inflammation, infection, or both. So it says that the diagnosis is when there is maternal fever with one or more of the following, and they are fetal tachycardia more than 160, maternal WBC count more than 15,000, purulent discharge from the cervical os, and number 4 is biochemical or microbiological evidence in amniotic fluid of amniotic infection. Then we label as triple I, and the term polioamnionitis is no longer used.
So another question is is it always essential to take a consent of lumbar puncture? Sunil, maybe what do you think?
I think we should. It's not an emergency procedure. So whenever there is a non-emergency procedure, we should do a consent, take a consent.
And what do you explain?
Yeah, that's the thing. I think that's the crux of the story. But most of the time, it's not in newborn, or we are not seeing any complication as far as in LP. It's reasonably safe procedure. But I think we are taking actually consent before LP, and there is no problem as of now with consent. With these days, I think.
Okay, you say the point is that you should definitely take it. How to identify culture negative sepsis? That's a very interesting question because I thought we had answered that. But anyway,
I think before saying that, I think we should this culture negative sepsis in West. This says they do not exist. So gradually we have to realize that these are not they are not always sepsis. First thing. So there are scenarios where the culture will be negative. But if the clinically you are thinking it's sepsis and you're supported by sepsis parameters, then I think we should stop anywhere between 5 or 7 days.
Correct. So, we have not talked purposefully, but somebody has asked the role of micro ESR in diagnosis. I do not know how many of panelists are actually doing micro ESR now.
We used to do during our residency, but no longer doing now.
Yeah, so Shiva, that answers your question. If all these experts are not doing, you should also not do it.
Just one thing to add, Dr. Wazir.
Sure.
We are always focused on bacterial sepsis. We must not forget the infections like herpes simplex virus, etc. Because you are getting the culture negative does not mean that these infections are not there. So these should always be there in the back of the mind if the child is very sick and culture is negative.
Correct. So any child who deteriorates towards the later part of first week or the second week, you should always suspect a viral infection, and very early you could probably have enteroviruses. Now Ravi Khanna, I think from Bareilly, he's asking this question: cost of biofire, and he's not going to like it.
I think 15,000. It's 15,000.
Yes,
20,000, yeah.
it's around 13 to 14,000, and for some units like yours, Ravi, probably it may not make much sense. But for ours, like the cost of therapy of one day is like 15 to 20,000. So, and the parents want to get rid of that like anxiety. So sometimes we end up doing biofire in that. These are the questions. The biofire is commonly not available in common labs. So there is a specific lab which does it, but you have to find out whether your city has to accept those sample or not, because it's not done routinely at all hospitals. Biofire also, the question is, does it test anything? As I said, there is a respiratory panel, there's a gastro panel, there is a meningitis encephalitis panel, the blood culture panel. So it's basically a PCR, like a COVID-19, it's a PCR based test, which can be done on any PCR material from any site. So what is the advantage of biofire over already existing syndrome evaluation system? I think maybe what you mean, Suja, is, if I'm not, maybe a panelist can get it right. What is the advantage of biofire over already existing syndrome evaluation system? Maybe you wanted to say blood culture and
No. Syndrome evaluation is the multiplex PCR only. So actually the same thing.
is the same thing. Okay, that's why I
Yes.
thought, like, if Suja's put in question, there must be some sense. I'm not getting it.
One question I forwarded to you. It came to me that does lactoferrin have any role in preventing
Yes.
this?
Coming to that, does lactoferrin?
There are one or two studies which showed some benefit, but overall it is not available. It is not recommended as a blanket therapy to everyone.
There is evidence, like it decreases late onset sepsis, but only thing the quality of studies are quite low. So, and availability is an issue. So
Availability is an issue. So one question, which is so very, very simple question: what is the harm in giving probiotics? You said studies are not there. So what is the harm? This is Mukesh's question.
The biggest concern of harm in people is, one is whether they will introduce sepsis while giving probiotics, like the risk of contamination. So one should ensure the hygienic preparation of probiotics. And secondly, whether there will be intolerance of the probiotic itself. And secondly, when you are not feeding the baby, how to give probiotics? That is another problem.
So that's no harm as such. The sepsis related, related to probiotics are basically case reports, one or two coming up. Like so this is not an epidemic. Even if any trial has not shown us this thing, but it's a cost involved in doing this thing. So if you think that you have a high incidence, you're going to really make a cost benefit and benefit to the unit. If your incidence of sepsis is low, you're mainly treating 32 weeks and above, then you don't need to use it. Like a term babies, probiotics has no role, as far as prevention. So you're adding through the cost. But if you have a high incidence of low birth weight babies and you have a high incidence of infection NEC, maybe considered, given all the limitations which were discussed. Role of exchange transfusion in neonatal sepsis has already been answered. How many times it can be done? If you're done once, then no point in repeating it. Jamuna, then if it is not benefited you once, then it's not really going to help you. Amit, like, if culture report shows gram-negative organism resistant to all possible antibiotics available, and the baby is also sinking, which antibiotics to use? And this is, I think, what he's saying: multi-drug resistant, carbapenem resistant, and colistin resistant. What to use? And I think indirectly what he wants to ask Amit is, should we be using the tigecycline, which is the only left in that category, and is a tetracycline? So Naveen, maybe you can answer that yet.
No, luckily I have not used tigecycline, and I am very afraid of using it also in newborns. And I'll try not to use it unless and until the culture shows only this drug, that this is the only drug which is sensitive, not as an empirical therapy at all.
So I have, like, again, I have the data from 6 babies where I had used them. So it's like, but that was largely about, in the previous hospital I was using, where in a particular setup from Rewari, we were getting only imipenem resistant, colistin resistant babies in shock. And out of 6, 3, despite the use of tetracycline, did not survive. 2 survived, but I did not have a long-term outcome after 1 year. And 1 actually had, I saw it around 1.5, 2 years, had teeth which were gone. I did not investigate the bones, but probably there must have been something in the bones also. So this is something which at that time we used to get a consent from the parent that this is the only thing which is going to be useful. You want to use it, fine, but always take a medical legal aspect, which I think, Pradeep, you also wanted to cover that, no?
Yes, most often or not, you are just pushed to the wall. It's multi-drug or pan-drug resistant, actually, I will say. We have encountered 2 or 3 cases where it was resistant to colistin also. So now the baby is dying, you are not left with anything. And if the parents Google and read the literature, then they will read tigecycline is not approved for newborns. Now you have to explain them in writing with video counseling because the baby is dying. Then we are not left with any option. These are the drugs otherwise not approved for newborns, and the safety has not been proven, and the sensitivity is only to these drugs, and we are not left with anything. So it's a choice that you are left with.
Yeah, probably right now the response to this organism, most of the drugs, 70-80% of the drug which we are using is not recommended for newborns. Now I also don't have the answer that what to do, and if someone goes to the court, then what will be the our answer and what will be the our defense.
So the question, Sunil, can antibiotics be given at home without admission after the child is stable? So this is probably, there are 2 aspects to it. He's not mentioned, but I'm saying, can IV antibiotics be given? Yes or no? And can the child be treated with oral antibiotics if the child is like off?
I think if the baby can be dischargeable, stable, and you have to complete the course of antibiotics, let's say for 3, 4 days, 5 days, I will still suggest we continue. We can give IV antibiotics at home rather than switching to oral. As of now, we are not using oral antibiotics to complete the course. To complete the course, I think IV antibiotics has to be given as far as newborns are concerned. And it can be given in home.
So the point is, you can give it like under supervision, but they have to make sure that nobody's pushing those antibiotics. So still needs
that you have to ensure who is giving, how is giving. So under your supervision, under your guide, antibiotics for 2 or 3 days can be given in home. Probably we are discharging early and we are saving some rupees of the patient. Then why not?
And Suja again has a very tricky question for maybe her friend Gopal. Should we still stick to 14 days for culture positive sepsis protocol? Irrespective.
So 14 days is not. To break that protocol, we need strong evidence. But if you look at evidence, even around PGI study, there is a Delhi study which looked at 7 days versus 14 days antibiotic. And they found that the relapse rate within 48 days of readmission and actually getting readmitted or having recurrence of this thing actually increased with 7 days of antibiotics. So as of now, the evidence is not strong enough to curtail, but definitely if gram-positive sepsis in cons, definitely take these to 7 to 10 days. Gram-negative still, I think I would stick to 14 days.
Yeah, gram-negative severe case of sepsis less than 14 days is slightly risky. If it is a risk factor based, then you get a relatively low symptomatic babies. You may consider shorting to 10 days or so. But severe symptoms, severely sick babies less than 14 days is too risky.
Let's give them one answer. A child who has been had a very severe course in the NICU, in that case, you would probably not do less than 2 weeks.
Yeah, and maybe more if there is a meningitis or the response is slower. Not less than.
If the child grew gram-negative on day one of admission and improved in 2 days, that is where Suja is trying to put across. And improved in 2 days, the child is like, why do you want to give it for 14 days? That's the question she's answered.
but we don't have evidence to change that protocol. That's it.
So Suja would generate that.
Suja evidence. So you need evidence, strong evidence to change any standard practices.
Right.
But we don't
Gram
have
positive, you can take the risk of lowering it to 7 days or maybe 10 days, but probably not in, should not be in gram millimeter.
So sometimes, like, when, we tend to do it when the cannulation is a difficult problem, we sometimes tend to do it, but not as a routine. And in those scenarios, when you're shortening, remember that, like, Suja, that's again anecdotal. I would suggest that you should repeat a CRP or, like, see there is no inflammatory marker which is still present and is going to be, like, there. You can't really be complacent with the blood culture positive sepsis. Amar has a question. What specific level of ANC you would want to start GCSF? Gopal, you answer that.
Sorry, I didn't get it.
Which level of ANC you would want to start GCSF?
GCSF. So, like, current evidence is like less than 1700 of ANC, and baby should have severe symptoms of sepsis. Then you can consider GCSF.
Like, for sure, less than 1000 you will be very
definitely.
Yes, less than 1000 you will be. After that, if the child is depending upon the severity. Arjit, hi Arjit. He says, what would be the choice of antibiotics in suspected late onset sepsis, bar meningitis, and how is piperacillin for meningitis?
So I think antibiotics we already discussed. We need to choose as per our own local culture and sensitivity pattern. Suppose you have meningitis, definitely you need, I would say, using cefotaxime would be better because cefotaxime has good CSF penetration. But piperacillin is not bad. Some books say that piperacillin is a poor penetration, but piperacillin also, along with tazobactam, it has good CSF penetration, can be used alone also.
Yeah, so it's like, so platelet count and septicemia. Sunil, maybe you answer that.
Platelet counts
In septicemia, because most of the question is platelet count in neonatal septicemia. So they tend to fall, and most people get worried because the platelet not improving. The child otherwise improving, but the platelet count is like still 30,000, 40,000. Then they should be changed antibiotics now.
With treatment, clinical symptoms will improve, but platelet count will not improve at that time. Platelet count takes time to improve. So simply if the platelet count is not improving, do not change antibiotics. It doesn't say that the antibiotics is not working.
Correct. So what point?
We should not worry about low platelet count. Like say the threshold for transfusing platelets is these days 25,000. So many times we see there's a separate domain I will say, but about 30,000, 40,000 we are giving platelet transfusion. But most of the babies they do not require platelet transfusion if it's above 25,000.
One thing to add, if it is a persistent thrombocytopenia, you are giving only antibiotic and you don't have the culture, you may be having culture. Do think of fungal infection also when you have given a prolonged course of antibiotics and still the platelets are keeping it low persistent.
Yeah, so the point where, like, I don't know, the name is not there. So after a sepsis, there is a bone marrow suppression, and which is more for gram negative and fungal infection. So your possibility of recovering is between 7 to 14 days, and from gram positive, it could be anywhere between 3 to 5 days. But if Dr. Naveen was saying, if your platelets are persistently low, look for complications. They may be infective, non-infective, but look for complications.
If there is no clinical bleed or asymptomatic, I would say wait till 25,000.
Right.
This is current evidence.
Wait till what?
25,000.
25,000.
Right, certainly.
Not above 25,000.
Right.
And you can have antibiotic-induced thrombocytopenia also, which you have to keep in your back.
Yes, and heparin-induced as well. So TG-cycline used in neonates, we have already discussed. It's a tetracycline, and if Pradeep has said that medical legal aspects to it, do not do it. CRP used in sepsis, we have already covered. Culture negative fungal sepsis, that's an interesting one. So fungal cultures are generally not positive and presumptive. So culture negative fungal sepsis, how long to treat, with what you need to treat?
Usually fungal culture gets positive. You have fungal sepsis and the positivity rate is quite high. But if you still you don't have the culture positive and you are highly clinically, you have the clinical signs and symptoms which are consistent with your fungal culture, then obviously you have to treat it. But theoretically speaking, when you are treating a fungal culture, then you have to repeat a blood culture again after 2 weeks and see that your fungal culture becomes negative, and that therapy is 2 weeks after your fungal culture is negative. But if you don't have a culture and you are empirically treating it, but probably
For empirical,
not less than 2 to 3 weeks. If you don't have meningitis, then not less than 2 to 3 weeks.
so Naveen, for empirical therapy, you use fluconazole or amphotericin?
I personally use fluconazole for empirical therapy for those babies who are not very sick.
I think that answers the question. So when should we do PCR? I think they're talking of the biofire only. Pradeep, you can answer that, please.
Yes, biofire, whenever we are doing blood culture, if we do biofire, the advantage will be we'll get the report earlier. That's the only advantage that we have. So there is no specific indication for biofire. It's just like any other culture.
Yeah. So that we say it's one way to find out about the organism faster if you want to do it. So that's about role of immunonutrition, glutamine, arginine in neonatal sepsis.
No role right now. No evidence to support
One
that.
line answer is enough. In preterm, 28 weeks, exchange transfusion preferred. I think Gopal already answered. High risk of IVH. Oh, that's interesting. That's Jamuna saying, can you please tell about antibiotic dilution? That's an interesting one. So maybe we have a chart, so we can share it with you if you can leave your, or you can look at Neofax or any other, formulary. It will be there how to dilute.
So better prepare a chart and fix it so that you don't have to search every time.
Right. And how can we do in medical college Kathua and Doda, where this must be from Jammu, I guess. This is for me, where infrastructure and their training and trainees are 0 or less. As you are also Jammu, it's question to Dr. Sanjay Wazir. So I knew that. So that is what. So I say everyone started the same way. So whether it was AIMS or PGR, nobody made an institution in a day. So it's a commitment which goes into making. So, and many of things where you see, if you are getting upset at medical college level, think of Dr. Ajay Bhang or Abhay Bhang, who's working virtually. He started his project and saved so many lives in those that particular tribal district of this thing. And if you really want to read more, reading his story and his Lancet papers may be a good way to inspire yourself. I hope that answers your question. Ravi Khanna, I have used tigecycline in desperates, where it's the only sensitive drug. In few occasions with colistin 20, results are not good. It's a bacteriostatic drug. Tigecycline is a bacteriostatic drug. Yes, all tetracyclines are bacteriostatic drugs. I mean, it's just that we said possibly we did not have an answer, and none of us have actually any experience about a long-term experience. So whatever we are saying is probably a personal experience which may be completely wrong. So Ravi, maybe if you used in so many patients, maybe you can produce that paper. Oh, how frequently do a chest X-ray to be done in pneumonia?
How frequent?
हाँ, X-ray एक बार तो कर लिया pneumonia diagnose के दोबारा कब करना?
If the babies improves clinically, then there is no need to repeat X-ray as such. Especially the babies who are not ventilated, not on any respiratory support.
So answer is 0.
Yeah.
Radiological clearance will
baby
take
improves clinically.
So radiological clearance takes up to 10 days for the X-ray to get cleared. So never look at an X-ray if the child is improving. Can early onset neonatal sepsis baby deteriorate after 36 hours of life who were previously stable? I did not understand the question, but probably what it means.
Yeah, they can deteriorate if you are giving antibiotic to a sepsis and the bacteria is not sensitive to your antibiotic. They can deteriorate. But in preterm babies, do look for other illnesses also, IVH, PDA, and all sort of illnesses. That it is not always the sepsis which makes the baby deteriorate.
Right. So Priya has a question, an interesting one. ELBW baby has hyperglycemia. Does it always mean sepsis?
Not necessarily. ELBW babies can have hyperglycemia without sepsis also. But if there is hyperglycemia, we should otherwise look for sepsis in any case. But they sometimes have the less capacity because of the low muscle mass to utilize that glucose. So sometimes lower glucose or rarely even insulin might be required.
But probably normoglycemia initially, then sudden spurt of hyperglycemia is maybe you have a high suspicion that this baby might be getting infected.
Okay, last 2 or 3 questions. Congenital pneumonia, duration of treatment, 7 days, 10 days? Just
5 to 7 days.
So just 7 days. Okay. Is it mandatory to add antifungal after prolonged antibiotics for 2 weeks? If the child is not symptomatic, there is like, you're not treating any infection.
No, not at all. If there is no clinical signs consistent with fungal infection, you don't add as a routine.
Right. Which probiotic is best suited if I have decided to use? Which is the best one? And the benefits we have already talked about. So the answer is that you need to use a reliable source from a company which is a reasonable experience in the probiotics, knows the storage, and if you have a local company doing it, please do not do it. Look at literature whether that particular brand organism has been tested in newborns, has shown benefit or not, and then you would probably use it. Not every probiotic which is available in the market. Exchange transfusion is not the only option. In fact, we are not saying that exchange can be tried only in sick babies, so that answers. Antibiotic sensitivity is needed in all newborns. Yes, all blood cultures are associated with antibiotic sensitivity. That helps us decide which antibiotic to use.
Sanjay, you need to see the Amit's question also. Where is Amit? There is Amit's question. He's saying answer my question also. There is Amit Upadhyay. Which antibiotic need to be given over 2 to 4 hours or even longer in case with prolonged leaking PV? When to do CRP, CPC, PCT blood culture for earliest diagnosis of early onset sepsis? Please answer my question.
That question, Sama.
In a chat. Sanjay, can you see chat?
I was just opening the Q&A.
I think we need to have a long discussion with Amit. Maybe probably in the late hours we can discuss it with Amit. Have a conference call.
Amit should answer that. Amit should answer that. I think there's like a lot here. Did you recommend suprapubic tab for sterile in extreme preterm? Suprapubic tab. For sepsis. I think yes, I'll just show you.
We don't do urine culture especially. Only late onset sepsis where you have any risk factor where you can have a UTI, then you can do a.
So late onset sepsis, yes, you should do, and this is the method you should do.
So suprapubic is the method to do this.
And if not, then you can use this credit method to get. This has also been shown to get a clean catch, and this is published in ADC. I think right. Question answer last by I think I can stop.
Should we finish, Sanjay?
I think we should, unless you guys want to go further.
Yeah. Okay. Thank you very much.
I think. Thank you.
So thank you, Sanjay, and thank you, Sandeep, and bye, and Gopal. Sunil has already left. Okay.
Sir, before you finish, I think I must thank all of you. I must thank all of you for your time. I think it was a fantastic discussion. It went up. We have exceeded by 45 minutes. But in next 30 seconds, if you allow me, 2-3 things that I need to tell to the audience also. Yes, Bifidobacterium brevi M16V is available in India, right? This has been available in a sachet form. So there is no question of keeping it. The storage is not an issue. It can be mixed jolly well with the mother's milk or the sterile water to be given to the baby. It is till date the most documented probiotic having used across the country, and recently Tamil Nadu government has also taken it for the government supply, that Bifidobacterium brevi M16V, and our endeavor in Tablets India is that if you are able to save at least one baby's life also, so that's why this is called Rescue Every Neonate. Rescue Net is the brand. right? And it is used for the prevention of neonatal sepsis, that the late onset sepsis, even in prevention of the NEC, it increases the feed tolerance, right? All these things are there. And sir, we really value your time, and we hope that this web talk have certainly added value to your clinical practice. We at Tablets India, we are dedicated to serve you more efficiently, and I'm sure with your support in the days to come also, we would like to conduct such type of program, which is definitely beneficial for hundreds of the audience who are there. I thank all the esteemed panelists and Sanjay sir, our moderator for the session. I think thank you so much. Thank you very much. Stay safe, stay healthy, and take care. Thank you so much.